I'm going to kind of skip the beginning just because it's the same PowerPoint from last time with the combination of depression and anxiety. And so usually I have kind of the disclaimers up front, as well as any potential conflicts of interest, which I don't have. But because I didn't want to sit here and scroll through 30 slides while you guys are watching, we're just going to start with the anxiety disorders that we're planning on talking about today. I know Troy has posted the lecture for availability on the ECHO website. But we're going to kind of extend this. I'm happy at any point to have discussion, conversation. If questions come up, stop me. Feel free to ask questions. I've got, I don't have to finish everything in order through. But really, from anxiety disorders, from a DSM standpoint, the classification is a little unique here because they've kind of laid out their chapter based on a developmental progression. So likely separation anxiety disorder is the first to present in childhood. Selective mutism coming in a little bit later, anywhere between 8 to 13 years old, with a peak between 11 and 12. And so it kind of goes down in order of age of when we expect anxiety disorders to be presenting, which also is nice when we're using the DSM as a guide because it helps us keep in mind what we kind of should be looking for based on the age of the patient we're seeing. So in a 6 to 7 year old, it's much more likely for us to be seeing separation anxiety disorder than it is development of a generalized anxiety disorder. Even though that can happen, it's not as common. The same thing with comparing it to social anxiety disorder, which typically presents between middle school to early high school. We're much more likely in a pediatric patient to be having, when we're having school anxiety and other things, that it's more likely to be separation anxiety or selective mutism, depending on the presentation. And so it kind of gives us this picture of how these develop from a chronological order and age so that we can guide our diagnosis better when we start to look at the specific symptoms of anxiety disorders. The highlighted ones are the ones I wanted to focus on today. We have to keep in mind things like substance and medication-induced anxiety disorders. We often get this, and I do see a different population of kids because we are seeing the kids with more severe mental health disorders. But people kind of look at me odd when we talk about evaluating for substance use disorders in kids as young as 8 and 9. But in reality, when we look at a lot of our data surrounding onset of substance use with people who have the genetics for addiction or access because of families who have addiction in the families, most onset in kids that are very high risk occur before the age of 12. We know this when we look at our National Youth Risk Behavior Survey data, that there's a large percentage of kids, when they evaluate these high school kids through this national survey, that say their first onset was before the age of 12. It doesn't break down to specify before that. And so I don't think it's actually too early to start screening for substance induced, especially if we have an abrupt onset of anxiety and we're seeing abnormal behaviors like school failure or withdrawal from families or other acting out behaviors. But then also keeping in mind stuff like PTSD and bullying, which we're not covering in the anxiety disorders, have to be screened for as well. So I actually start screening for substance induced or substance use plus any relation to anxiety or depressive disorders at probably 8 or 9. I start asking families if there's any concerns, what the family history is, starting to ask the kid about their knowledge of substances, because we do see kids as young as 10 and 11 that may be coming in with substance-induced anxiety disorders. Some common features of anxiety disorders. So what we tend to see in adolescents or in kids is a lot of excessive fear and anxiety. Most of it, and I hear this often, most of it is not reasonable or logical. And so I hear a lot of families who don't understand anxiety, or even, referrals from other people or teachers saying, well, they don't have anything to worry about, they're too young. Well, that's the entire point of anxiety disorders, is kids are worrying about things that they don't really need to, or they shouldn't have a reason to. Talking about finances or future goals. I've had 6 or 7 year olds having anxiety attacks because they're worried about what's going to happen with high school and getting into college and their future. And I mean, it's just highly unreasonable, but also things that we may not be able to anticipate, and keeping in mind current events. And so we'll have kids coming in talking about hurricanes or tornadoes they saw in the news in the South or back East, where in Reno we have zero chance of these affecting us directly, but you have kids coming in losing sleep over this, worried about this. So this excessive fear and anxiety tends to be often illogical and not necessarily recognized by the family either. So fear is an emotional response to the real or perceived imminent threat. And then what we define anxiety as is this anticipation of future kind of problems that come up. Fear often is related to surges of autonomic arousal and fight or flight. So again, the DSM kind of breaks this down. So when we activate our fight or flight system, that's often fear related, whereas anxiety is more often associated with muscle tension, vigilance, or avoidant behaviors. And so fear and anxiety kind of go hand in hand, but we can break them down a little bit based on kind of the origin of, is this kind of cognitive thought process leading to these symptoms, or is this the autonomic nervous system kind of setting us up as primed for physical symptoms? What we tend to see in anxiety disorders is they tend to share a lot of features. So we tend to see a lot of somatic symptoms in kids. 8 to 13-year-olds is when we see the most somatic symptoms present with anxiety. We see it a little bit in younger kids, but a lot of stomach complaints, a lot of headaches, a lot of just not feeling well or avoidance, more so on school days than on non-school days, or before social events. If it's a social anxiety disorder, we will see it happen where, hey, maybe it's not school as much because they have a small group of friends that are close with, but any sort of social activity. And so we can start to kind of correlate this when we do our physical assessment and history, is that when these are occurring before certain triggers, we're more likely to relate it to anxiety than if, you know, the headaches, the GI are kind of not related to specific events. We tend to see a lot of adult accommodation. So adults tend to accommodate anxiety quite a bit, and this can actually be something we can target with treatment. But it's kind of this process that reinforces anxiety tends to worsen it. So we see kids with separation anxiety or with social anxiety or generalized anxiety, and they start to develop somatic symptoms, or they say they don't feel well, they're trying to avoid something. And what our typical response as parents is, we want to meet the needs of our kids. And so we say, okay, you don't feel like going to school today, you're not feeling well, you've got a stomach ache, we'll just keep you at home. Well, psychologically, what that does is it tells our brain that anxiety, that fear basis is really, really bad, so much so that we had to stay home today, we weren't forced to go into this. And what it does is it causes, over time, a heightening of the anxiety because we have a lot of adult accommodation for this. So it's actually making the disorders worse, it's making the anxiety worse by saying that the appropriate response is to avoid the thing making us anxious. And kind of our entire goal of therapy is to get kids to experience anxiety in the setting that makes them anxious and learn to deal with it so it can decrease that anxiety over time. We see this with separation anxiety. Mom and dad are getting ready to go out on a date, and Johnny isn't feeling well, starts to throw a tantrum and saying he has a headache and a stomach ache. So parents cancel the night out. Johnny starts to feel better, and what it says to us psychologically is, it was really bad that they were going to go out and they decided to stay home. And so that was something we really, really needed to be afraid of. And we tend to accommodate that anxiety. We tend to see a lot of avoidance, whether it's through somatic symptoms or whether it's through acting out, tantruming, freezing type behaviors. Avoidance is a common way that we cope with anxiety. However, avoidance also leads to heightened anxiety over time. Most anxiety disorders have a presentation in childhood or adolescence. So we start to see anxiety disorders present fairly early, even generalized anxiety disorder in early adolescence. Very few anxiety disorders have a kind of course of illness where they come on in adulthood. And so we start to see anxiety start very early. A lot of it has to do with a combination of probably genetics and then modeling within the home. When we have anxious parents or anxious siblings who are modeling anxious coping skills, we tend to pick up on that anxiety and we tend to follow them in how we deal with and cope with anxiety. And so there's a combination of kind of this genetic environment interaction where we're getting modeling, but we probably also have the genetics to be primed to be anxious. And so this can tend to happen. Most anxiety disorders, minus a few, tend to worsen over time. And most often they're triggered by some sort of exposure or event. So separation anxiety is probably the most common that we see in childhood. This presents very similar to social anxiety. So the hard part is figuring out the fear basis that underlies this. So separation anxiety is essentially this developmentally inappropriate and excessive fear related to the separation from our primary caregiver or family members. And so we have at least 3, there's 8 symptoms here, and a lot of it is anticipation about something bad happening to our primary caregivers or family members. So we're afraid that something bad is going to happen to mom, dad, or sister. It could be a nanny if that's the family dynamics, or another caretaker in the house. There's kind of persistent and excessive worry about losing the attachment figure in some way. We tend to have a lot of excessive worry about experiencing some bad event coming to them. We get nightmares about it. It's hard for us to stay away from home. So when we go to sleepovers, we're calling to come home because we're afraid something bad's going to happen. We don't want to sleep alone. So these kids often are kids at 8 or 9 who are crawling into bed with parents because they had a bad dream, or they can't go to bed without mom and dad laying in bed with them. And there's a lot of physical complaints that come along with this. So we get a lot of refusal to go to school because we're afraid to be separated from our attachment figures. And we tend to have a lot of somatic symptoms presenting in that presence of avoidance. So we're getting ready for school, we have tummy aches, we have headaches, we don't want to go to school. And the thing is trying to figure out underneath that the primary focus is that they're worried about something bad happening to our close family members or caregivers. Typically, we don't diagnose until symptoms have been there for at least 4 weeks in children and adolescents. Typically for adults who develop this at 6 months. It's causing some level of clinically significant distress or impairment, socially, academically, within the family, and it's not better accounted for by some other level of mental health disorders. Selective mutism. So this is interesting. Most people will never see this. You might, pediatricians might see this first because concerns come up a little bit quicker. But this is really, we see a spike in this around 1st grade, maybe 2nd grade. It's kind of this transition to school, which is when we see the biggest spike. And what we tend to see is a consistent failure to speak in specific social situations where there's an expectation for speaking, and we have normal speech elsewhere. So this isn't due to like autism or other speech delays. It's not necessarily due to problems with being able to comprehend language. It's primarily we get into a setting where we get so overwhelmed and anxious socially that we kind of shut down and just refuse to talk here. It tends to interfere with educational, occupational achievement, at least a month in duration. And then we had those kind of rule outs. 1st grade is when we tend to see the biggest spike in this, or 2nd grade. The hard part is that we often have a lot of school accommodation for this. So a kid gets in, they shut down, they're nervous, they're anxious, and they find ways to accommodate, and the school finds ways to accommodate. So they'll let them speak through their best friend who sits next to them, and they'll whisper to them. They don't make them speak in front of the class. They kind of just take it off as they're shy or quiet, and so they don't force them to do these things. And by not actually encouraging them or forcing them to speak in social situations like in school, they actually shut down even more. And so we have kids where we'll get consults for this who are in the 4th or 5th grade who haven't spoken in school since the 1st grade. And now we're fighting an uphill battle because it didn't get addressed pretty quickly. So this is one that may get addressed by pediatricians right away because there's a concern. They show up to school, they're getting reports they're not talking, but they seem fine at home, they seem fine with friends, everybody knows they can talk. You know, it's not a personality thing. It's likely related to extreme social anxiety or extreme shyness or something else, and in a situation they're not comfortable with. Most of our treatments are going to be the same when we get to anxiety disorders, but the goal is going to be with these kids is to get them into therapy potentially medications if needed, but it's to encourage them to talk in social situations, to get them a little bit uncomfortable, and to show them that, you know, the kind of, from a psychological standpoint, that they're not going to be made fun of or embarrassed or anything like that by speaking in class, and really focus on kind of those aspects of it. Some kids we do have to put on medications because it's just so severe, but typically it's therapy, which is the primary treatment. Social anxiety disorder. So this tends to present a little bit closer to middle school age. We tend to see it start to come in around 8 years old. We tend to see a spike around 11 or 12 where it peaks. And social anxiety disorder tends to get worse over time. This isn't one of the ones that gets better. Separation anxiety tends to get better over time as we get older and we experience separations naturally. We're forced to go to school, parents have to go to work, they go out. Separation anxiety is something that there's a natural level of exposure to, and so it tends to get better over time. With social anxiety, it tends to get worse over time. This is something that if it lasts into adulthood is very, very hard to treat. And severity is actually the worst in young adulthood if we develop it during adolescence and don't treat it. So this is primarily fear or anxiety about social situations in which the individual is exposed to or possibly scrutinized by others. So there's underlying fear basis that we're going to be judged, that people are going to judge us harshly or negatively if we do the wrong thing, if we say the wrong thing, having conversations, meeting unfamiliar people, being observed by others, eating or drinking, and performing in front of others, giving a speech in school. Middle school and high school tend to be where we start to really see the spike, primarily because from a developmental aspect, we go from a fairly small neighborhood-based elementary school, which has a lot of familiar people into it, and we go from having a single teacher all day, every day in elementary school, and we have this huge developmental leap where we go into junior highs where we have 6 different teachers, there's 6 different periods, we have different kids in our class with us at every period, and our community expands beyond our neighborhood to kind of a group of neighborhoods with kids that are unfamiliar. And so it's a massive spike in social interactions and having to navigate kind of this network of having a bunch of different teachers that you're unfamiliar with and a bunch of different students that you don't get to spend a lot of time with to develop relationships. And so because of that, kids can shut down, they can become anxious about it, they're unfamiliar with the other peers, it's a larger school size than we're typically used to. And that is a huge developmental step for somebody who's 10. You know, I think most of us who work with education just think it's normal, but from a developmental standpoint, it's kind of this abrupt cliff that we have to jump off of, going from, I was in the same class 6 hours a day with 20 kids for an entire year and one teacher, to now I might rotate through school with 80 kids or 120 kids and 6 different teachers and nobody knows me, and I'm expected to talk in front of them and talk in class, and that's a huge developmental aspect that can come with a lot of anxiety. The big things here is that we have to show some level of ability to develop relationships, both with our own peers and with adults. So this isn't something like where we do great with all adults, but we've never done good with kids, and maybe we're looking at other neurodevelopmental disorders. But we have friends that we're good with that are our age. We're able to interact with close adults and develop relationships. And this is kind of a big jump in change of how we present in social situations. There is a subtype of social anxiety disorder, which is performance only, you know, in the DSM and other areas, we just call it performance anxiety. And this is primarily limited to only fear related to speaking or performing in public. So getting up in class and giving a speech or presentation, those type of things. We see this a lot more with adults having to give up and teach or present to the company or corporation. But it can start in adolescence as well. And this is primarily with performance anxiety, something that can be relatively well treated as long as we can get people with some exposure to do these types of things. A lot of therapy goes into working up towards social interactions. So we set up kind of graded exposure type of therapies where We start with a graded anxiety where we talk about imagination of the anxiety. What does it feel like when you're talking in public? We work up to tolerating that. And then it could be, I've had as simple as families where let's go just sit in the Walmart parking lot in our car. And then we work up to getting out of the car, and then we work up to walking just up to the front of the building. And then we work into actually going into the building. And so we have these stepwise, graded therapies where we work up to the exposure, and it's not just a let's throw them in and flood them. But it's a big thing. About 75% of all cases of social anxiety present before the age of 15. So this is really in childhood, adolescent onset disorder. And then the disorder, the longer it lasts, the worse it does as we get into adulthood. Generalized anxiety disorder. This is our typical big one for adults that we all know. But in kids, we tend to see it present a little bit different. We have to have excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. And it's somewhat vague. So work, school performance, friends, future, finances at home, anxiety about our family. We do find it difficult to control the worry. And in adults, you have to have 3 of the symptoms. In kids, you have to have only 1 of the symptoms. I have never seen generalized anxiety present with just 1 of the symptoms. I think that anxiety is much more kind of pervasive than that. But the typical symptoms are restlessness, feeling keyed up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. I think I've never diagnosed anybody with just 1 of these symptoms. The most kids we see is they can't shut their mind off at night. They're just racing thoughts about something that's happening the next day or about other worries. And then they get easily fatigued during the day because of all the worry, or they're feeling really tense. A common presentation in kids is irritability. And this is one of the hardest things because of the overlap of irritability with other neurodevelopmental disorders, with depression, with ADHD, as anxiety can be a source of irritability. And so oftentimes irritability combined with an inability to shut our mind off to go to sleep and having trouble falling asleep is a key that there's probably a generalized anxiety disorder going on. And it's really doing a good job of screening for the underlying anxiety. As with all the others, we do see a lot of physical symptoms, somatic symptoms that are coming up. And then making sure, especially in adolescents, that we're screening for things like substance use disorders. So with generalized anxiety, the essential feature is excessive worry and apprehension about this. We tend to worry excessively about competence or quality of performance. We worry about other people judging us here. Females are twice as likely as males to experience generalized anxiety disorder, and so we see this more often in women and girls. Symptoms tend to wax and wane, which is hard because it can get better naturally with time and may get worse over time. And we may tend to overdiagnose kids with children who have worry, just because there's a lot of transient worries between childhood to adolescence, and so it's making sure there's a lot of consistent excessive worries. Treatment of anxiety disorders, and then we'll be open for questions and discussion a little bit. First line treatments, we never want to do medications first line. That's never our first choice. We are very, very big on psychotherapy. Some kids with moderate to severe anxiety do need combination treatment with medications, largely because if you're so overwhelmingly anxious, you can't actually participate in therapy. So I do a lot of informed consent with families and talk about realities of medication use, that it's not going to fix anxiety disorder or take anxiety disorders away. One of the large purposes of medications for anxiety is to decrease the severity and intensity of anxiety so that we can get more out of therapy, so that we can actually process with psychotherapy and work through all of the coping skills and things like that. The most evidence-based is going to be CBT. Other psychotherapies have proven to be effective. We just don't have the evidence in the literature for them. And then parents who are in therapy for anxiety disorders, including their kids in their therapy or in their coping skills, has been shown to be beneficial as well. So if you have a 6-year-old who's developing a generalized anxiety disorder and the parent has JD and the parent's in therapy for CBT, just including the kid in the room while the parent is doing therapy is shown to be beneficial. There are some specific CBT options. So the coping cat is something for kids, for pediatric patients. It's a workbook that therapists can go through. I've had some families who are higher functioning able to work through it with their kids. It primarily identifies anxious thoughts, looks at coping skills, and comes up with a plan for how to deal with anxiety-provoking situations. That is for pediatric age patients. There is this CAT project, which was created for adolescents, so 13 to 17, which follows similar to the coping CAT. And it's manualized. Again, I've had some higher functioning families be able to work through it on their own, but it's recommended for a therapist to kind of work through it. It's a formalized guide for CBT for anxiety in kids. When it comes to medications though, our primary mainstay is going to be SSRIs or the SNRIs like duloxetine. Duloxetine has an FDA approval for 12 to 17 for generalized anxiety disorder. Otherwise, there's no FDA approved meds for anxiety disorders in pediatrics. We do have evidence for and support for sertraline, fluoxetine, escitalopram, and venlafaxine. So we can use those. Off-label, we use things like hydroxyzine, clonidine with ADHD kids, or guanfacine for ADHD kids who have a high level of anxiety. I am not a big fan personally of as-needed medication. I prefer baseline treatment of the anxiety. As-needed rescue medications essentially do something similar to an avoidance type of coping skill, is that you're getting really, really anxious. You take a pill, your brain tells you it makes it better because most panic attacks, a lot of high volume anxiety tends to start to dissipate after 15 to 20 minutes anyways. And typically our anxiety starts to resolve before medication is active in our system when it's a rescue medication, but it's telling our brain that we did something to make the anxiety go away. So we took a pill which made the anxiety better, not we were anxious and we were able to sit through the anxiety and it got better on its own. And so it tends to reinforce that anxiety and reinforce psychologically that we need a pill to feel better. So I am much bigger on like starting baseline SSRIs for anxiety if we have to use medications, or even if you're going to use something like hydroxyzine or clonidine, to schedule it. It's a daily medication or it's a nightly medication before bed to help with nighttime anxiety, and it needs to be taken every night as scheduled so that we don't run that risk of kind of reinforcing anxiety inadvertently. So that is all I have. Do we have questions?
Yeah, thanks, Dr. Fitzgerald. Sorry, everybody, I have my video off because the sun kind of comes through behind me at a weird angle and just flares out my camera, so I want to avoid blinding anybody with that today. So Brianna wrote in, is elective mutism a thing? Is it the same as selective mutism?
I've heard this term in a couple of different platforms. I would say it's very, very similar. The way I've heard elective mutism is they're choosing to do it. It's not in the DSM, but there is a component of selective mutism, which is thought that it could be in some kids about control and controlling the environment. And so it could be very similar in that they're just choosing not to talk. I think it depends on the basis of anxiety, whether or not we can see if they have any conduct type disorder or oppositional defiant disorder, if there's other actions that would say that this is purely a choice versus they're just overwhelmed with anxiety to the point they can't talk.
Okay, thank you, doctor.
You're welcome.
Thanks, Brianna. Dr. Eckert says, how can one differentiate the shy child versus one with social anxiety that may need to be treated?
So I think this comes back to kind of parents' view and a good developmental history of kind of what our baseline is. When we see the development of social anxiety disorder, it's a change from kind of our normal behavior. So when we look at shy kids or more reserved kids, they tend to be that way kind of throughout the developmental period. We talked about a history of when they were 3 or 4, they were kind of shy and sat off to the side. And that's kind of their personality. They have a few close friends of people they're comfortable with, but they've kind of always been a little bit more introverted, a little bit more reserved surrounding people, versus somebody who we see an abrupt change starting to develop it. They're outgoing, they have a lot of friends, they're kind of, you know, they're able to talk in all these social situations. We have family parties or friends over and they have no problem. Then all of a sudden they get to school and they just start to shut down and have a lot of avoidance. I would say probably the baseline versus an abrupt change is our biggest kind of clue to a kid being shy versus having social anxiety. I think inherently there's some level of social anxiety in shy kids, but it's really looking at, is this baseline personality from just who we are versus we see a big change.
Great, thank you.
So you're welcome. If adolescents struggle with anxiety and depression, how do you determine if one has led to the other or not? Also, how would you determine the treatment plan if the child is struggling with both? So this is a great question, because anxiety and depression can drive each other. Really, to me, it's semantics if they're meeting criteria for a major disorder. The DSM specifies it as if the anxiety develops during a depressive episode. So we get depressed first and the anxiety comes. We should be using this anxious distress specifier that we can add on to major depression. However, what we tend to see with panic disorder, with generalized anxiety disorder, is onset of these disorders tends to occur during depressive episodes. The depression gets better, but the anxiety stays. We also see the opposite, where kids who are super, super anxious can start to have, depression develop out of low self-esteem, out of concerns, out of a lot of kind of social interactions socially. So especially as we're developing towards adolescence, we can actually see depression stem from anxiety. I think the reality is we're going to treat them both together. We're going to look at focusing on getting them into therapy, working on primarily, and this is why we like cognitive behavioral therapy, because it's very evidence-based, but because whether it's anxiety or depression, cognitive behavioral therapy can start to address those underlying cognitive distortions, whether it's anxiety or depression-based. It'll start to work on kind of the low self-esteem thoughts, the apprehension, the uncertainty surrounding themselves. And so we can treat both at the same time. And the nice thing is with overlap, if it's really severe, the medications are the same medications we use on both. So we use antidepressant medications to treat both. And it's really setting up what we think is the most severe. Now, if we have a kid who has both and they're suicidal, or they're a high-risk kid for acting out, we need to be addressing those high-risk behaviors first and making sure that safety is addressed first and foremost before we move on to treating other aspects of anxiety and depression.
All right, I want to address some other questions that came in from Carrie. What behaviors are modeling children that nurture anxiety? How can we help parents and ourselves avoid modeling anxiety and depression?
So I think, and this goes back to some of the research, I think that we cope with anxiety. Most people cope with anxiety through avoidance. Something makes us anxious and we tend to avoid it. We don't want to do it. We find ways around it. And that's natural and normal. I think the hard part is when that starts to interfere with our social or occupational functioning, it starts to become a problem. So I think there's a level of avoidance of, if you're anxious surrounding dogs because you've been bitten in the past, avoiding a dog is going to be perfectly okay. But, and there's a difference between avoidance and kind of over avoidance or poor coping skills. And so we can talk to parents about how to model good coping skills. So, it's okay to kind of be cautious surrounding dogs and not approach them. And if they do come up to you, kind of put your hand out to test first versus, more phobic type of behaviors where we start to hyperventilate. We may pull our kid away from the dogs, tell them, go over there again, they're going to bite you, they're going to bite you. I think it's talking to them about, the likelihood of these events happening is very low. We can be cautious about these events. We do a lot of modeling with parents. So when we do therapy or even interventions within med management appointments, the parents are in the room for the coping skills. So my thing with therapy, especially with younger kids, is parents should always be in the room. They should know exactly what we're doing. So in effect, we're teaching the parent the coping skill to go home and work with the kids on. So breathing techniques, more mindfulness or distracting techniques is something that's making us anxious. What can we divert our attention to? And I think some good things are knowing how we can kind of help facilitate some of these things where parents may not have the skills. So I am big when it comes to breathing techniques on counting. So when people who get anxious tend to take deep breaths, they tend to hyperventilate, which makes anxiety worse. So we focus on, can we do more grounding based skills, or can we count? So 4 slow counts in and 4 slow counts out allows us to focus on the counting. And we can teach a lot of these techniques to the parents to go home and work with the kids on. You know, it's from a modeling standpoint of something that's making us anxious. We can talk to kids about their anxiety, their nervous. I know you're worried about this. It's going to be okay. Let's just go do it. You don't want to overforce a kid into a dangerous situation, but if it's something that doesn't provoke a ton of anxiety, you know, having them go to school if they're worried about it and walking them in and showing them it's okay. You know, if they're worried about going to a social thing, allowing them to kind of warm up. You know, you can hang out by us for a little bit and then we can kind of work our way in and talk to people, kind of working up to situations and being a little bit more slow versus just pushing our kids into situations that are super anxiety provoking. And it's also not accommodating. So the biggest thing is, hey, your kid is socially anxious about school. They don't want to go to school. We can't let them stay home day after day. Sometimes we do have to force them into going. And it might be setting up an option or rewarding them. You know, you can earn something if you go to school and participate today. So.
Thanks, Dr. Fitzgerald. Yeah, I want to try and get to the rest of these questions here. I know we're getting close to time though. So Alicia's asked, if adolescents struggle with anxiety and depression, how do you determine if one had led to the other or not? So how would you determine the treatment plan if the child is struggling with both?
So we addressed that a minute ago, Troy.
Oh, sorry about that.
Yeah, no, that's okay.
Sorry, yeah, Dr. Prokop asks, can you go over community resources for therapists willing to work with different age groups in pediatrics, 6 to 12-year-olds and 12-year-olds and up?
So there's a lot of kind of community resource. There's a massive list. Maybe I can get Troy the one we use from the state and county that we can have sent out. A lot of great resources. So Northern Nevada Child and Adolescent Services sees kids of all ages. Our fellows over there do see kids without insurance between 13 and 17. And so we can get them in there. They also have they have case managers who can help coordinate us elsewhere and kind of help get us connected with others. Nevada Hopes has a lot of great mental health care for pediatric patients, both therapy as well as they've started to include some med management for pediatric patients. And then there's a lot of like more private community-based places that offer therapy. So Midtown Mindfulness, Sage is another one. And so there's a huge list of places where they have pediatric mental health services for therapy. True North is a really good one that does a lot of DBT-based work for more high-risk suicidal kids. So I will actually get an electronic copy and have Troy send it out because the list of resources is kind of overwhelming. But I mean, worst case scenario is you call Northern Nevada Child and Adolescent Services first, and they can help guide you as well. So.
All right, I want to address one more question here from Dr. Knopel. Sorry about that. Dr. Fitzgerald, can you speak on PTSD and anxiety such as originates from chronic bullying?
Yes. So we've been seeing this more and more, especially with social media being a source of bullying. We tend to see a lot of anxiety stem out of fear, and this can lead to PTSD. It may not lead to PTSD. I think the hard part is knowing, especially with bullying, a lot of people may see some of kind of the taunting or the threats or the negative comments as kind of innocuous, that they wouldn't meet criteria for PTSD. Just because we don't see it as a life-threatening event, that doesn't mean it didn't provoke a fear basis in the child enough that we can consider it leading towards PTSD. I think what we tend to see is a lot of baseline hypervigilance and anxiety. We tend to be a lot more anxious in public or about going to school. I think one of the things that's really going to start to differentiate PTSD from generalized or social anxiety in kids who've been bullied is some of those really fear-based symptoms that we see in PTSD. So a lot more nightmares, intrusive recurrent thoughts that come up that we can't control, maybe more anger outbursts. So we're putting ourselves in situations that we don't have control of our emotions. We tend to see a lot more emotional dysregulation. coming with PTSD than we do with typical anxiety disorders. So we see kids having big blow up periods, especially when it has to do with a situation where they might be exposed to bullying. So it's really about talking to your kids. And I think the big ones are really like, how intrusive are those thoughts? Are we getting nightmares on a regular basis? But we tend to do see with the hypervigilance, especially surrounding school, if we're being bullied at school or online, is just a lot of baseline anxiety. It's not necessarily specific to worrying about things like finances or our future or other things, but it's more about the social situation. And so we tend to see kind of the differentiation be a little bit more social in nature, but have a lot more of those kind of severe symptoms than we see with a typical social anxiety disorder.